Hi, my name is Sarah Jennings, and I am an occupational therapist currently enrolled in the Masters of Clinical Science in Driving Rehabilitation Therapy program at the University of Western Ontario. Today, I will be completing my final presentation for OT 9752. Today's presentation will be based on a potential driving rehabilitation therapy client, Bob. Bob is an 82-year-old male recently diagnosed with early dementia. He was referred by his family physician for a driving evaluation. On initial assessment, it was determined that Bob has been driving for nearly 60 years and until recently did not have any infractions. Last week, he was given a ticket for driving 40 kilometers under the speed limit. His wife reports that she's sometimes nervous when Bob is driving because he does not always correctly attend to road signs. She never bothered to tell anybody because they live in a very rural town and thought that his driving was too slow to hurt anyone. She also reports that she does not drive, so if Bob doesn't drive, they have no other way to access the community. When asked how Bob would describe his driving, he reports, "Never been better. I don't know what all this foolishness is about." On further review, it was found that Bob has functional strength and active range of motion. He is independent with personal activities of daily living. His wife reports that Bob needs more frequent reminders to take his blood pressure pills and when he has appointments. He has a medical history of hypertension, type 2 diabetes, and osteoarthritis. Bob has two daughters that live out of province. Bob reports to go for a drive at least 3 times a day to see what is happening around town. Bob scored 24 out of 30 on the mini mental state examination. He completed the trail making test Part B in 3.5 minutes. I will now review the appropriateness of using the mini mental state examination as a fitness to drive assessment tool for Bob. To do this, I will follow a critical appraisal of instruments guide developed by Dr. Shirlene Klassen. The MMSE was developed in 1975 by Marshall Folstein, Susan Folstein, and Paul McHugh. It was developed to provide a quick cognitive assessment, particularly for elderly patients with dementia or delirium who are often known to cooperate for shorter periods of time. The MMSE is made up of 11 questions and takes approximately 10 minutes to complete. It is divided into two sections. The first section assesses orientation, memory, and attention through verbal responses for a possible score of 21. The second section assesses language and visuospatial abilities by the individual's ability to follow verbal and written commands, write a spontaneous sentence, and copy a complex polygon. The individual can score a possible 9 points here for a total of 30 points. The MMSE uses a ratio scale as it scores an individual on multiple areas and indicates the presence or absence of the trait. Failing an item means an absence of a trait and is a true zero. The MMSE can also provide us with statistical information such as means and standard deviations, which are characteristic of ratio data scaling. We will now review the reliability and validity of the MMSE. Results varied between studies on the reliability. The test-retest reliability was found to have varying results from poor to excellent when the MMSE was repeated over less than a 2-month period. Inter-rater reliability varied from adequate to excellent with a correlation coefficient or kappa range of R equals 0.63 to 0.97. Intra-rater reliability was found to be moderate with a correlation coefficient of 0.69. Internal consistency varied from moderate to strong in various studies, indicating a Cronbach's coefficient alpha ranging from 0.54 to 0.96. A study by Krizel and colleagues studied the MMSE as a predictor of pass-fail performance of on-road test. They found an area under the curve of 0.654 indicating a poor correlation of the MMSE's ability to predict a community dwelling. To score the mini mental state examination, 1 point is given for each correct response given by the client. There is a possible 10 points in the orientation section, 3 points for registration, 5 points for attention and calculation, 3 points for recall, and 9 points for language. The total points are added up and scored out of 30. There are various views on the cutoff norms to detect cognitive impairment. One study indicates a score of 24 and above as no impairment, a score of 18 to 23 as mild cognitive impairment, and a score of less than 17 as severe impairment. The MMSE can be purchased for $68 for a pack of 50 copies. No training is required to administer the MMSE. Here to the right is an example of the MMSE to show you that it is a quick one-page assessment tool. A study by Krizel and colleagues compared the MMSE with an on-road test for 168 drivers aged 65 plus to determine its utility in predicting fitness to drive in older adults. The study used 6 different cutoff points and determined its sensitivity, specificity, positive predictive value, negative predictive value, and level of error for false positive and negatives. Previous research indicates that cognitive impairment is present in a score of greater than 24, less than 24, and therefore the researchers began looking at scores at this point and above for prediction of fitness to drive. For the sake of time, in this presentation, I will only discuss the test properties at a cutoff score of less than 24 on the MMSE and its relation to predicting a pass or fail in an on-road test. Sensitivity was found to indicate that there is a poor probability that getting a score of less than 24 on the MMSE will indicate that the person will fail the on-road test. The specificity at this cutoff point was 0.98, which indicates there is an excellent probability that a person above this cut point on the MMSE will pass the road test. The positive predictive value at this cutoff was found to be 0.5, indicating a 50% chance that an individual will fail the on-road test with an MMSE score of less than 24. The negative predictive value at this cutoff was found to be 0.84, indicating a high probability that an individual will pass the road test with an MMSE score above 24. The error rate was determined to be 0.92 at this point, indicating a high probability of obtaining a false positive or a false negative result. Overall, the MMSE was found to be a poor predictor of a pass or fail outcome on a road test. I will now discuss a possible driving rehabilitation intervention to use with our client, Bob. This study by Davids and colleagues was completed in 2009. It is titled Effects of In-Car Support on Mental Workload and Driving Performance of Older Drivers. It was published in the journal Human Factors and based on research completed in the Netherlands. As individuals age, they have a greater chance of acquiring an impairment that will negatively impact their ability to drive. Such impairments may include reduced perceptual and visual motor speed, decreased divided attention, and visual and motor deficits. This study evaluates if the use of advanced driver assistance systems, also known as ADAS, while driving can compensate for age-related impairments to increase safety for older drivers. The research objectives for this study were: ADAS will reduce workload for older drivers. Older driver safety decisions will increase with the use of ADAS. There will be a greater acceptance of the ADAS by older drivers compared to younger drivers. This study used a 3x2 mixed between subject and within subject design and is considered a level 2 evidence. Age was a classification variable with young, middle-aged, and old categories. ADAS or no ADAS was the experimental variable. Within subject comparisons were made to test whether the dependent variable, workload and driving performance, were affected by ADAS. Between subject comparisons were made. 105 participants were recruited for the study. Recruitment strategies were not identified in the research. Of the 105 participants who were recruited, 48 dropped out due to simulator sickness. 17 others dropped out because they were unavailable for the study, leaving a total of 40 participants. Participants were corrected to functional rather than chronological age into 3 groups: young, middle-aged, and old. Functional age was determined by a pre-experiment assessment looking at perceptual speed, visual motor speed, and divided attention. The sample was 75% male and 25% female. Participants were included if they had 5 years of driving experience. They were excluded if they experienced simulator sickness. The study was conducted at the Neuropsychology Unit of the University Medical Center of Groningen in the Netherlands. It is unknown who delivered the study. The study was completed over 2 sessions. The first was used to eliminate individuals who had simulator sickness. The second session was the main part of the study, including a familiarization drive followed by 2 experimental drives, one with ADAS and one without ADAS. 40 participants completed the second part of the study, where they did a 35-minute drive twice, once with ADAS and once without ADAS. There was a 45-minute break between these drives. To reduce learning, 2 routes were used with the same intersections but in different orders. After each drive, participants completed questionnaires on motion sickness and subjective workload. After the completion of ADAS drive, participants also completed a questionnaire about their opinion of the ADAS system. On the ADAS drive, verbal messages were provided to the driver 9 seconds before they reached an intersection. 7 possible warnings were said to participants before they reached the intersection. Right-of-way regulation warnings were: 1. You are driving on a major road. 2. On this road, you have to yield to traffic from the right. 3. Attention, you are approaching a major road. Safe gaps to join or cross traffic at a busy intersection warnings were: 1. You can turn left, right after the next vehicle. 2. You can cross after the next vehicle. The obstructed view of the intersection warning was: slow down, you are not able to see cross traffic. A warning for a one-way street was: attention, turning left is mandatory. We will now review possible intervention biases. Contamination was not applicable as the study was designed so that all participants received the same intervention. The possibility of co-intervention was not reported. However, this is unlikely considering that the main part of the study occurred in one day. Timing effects were not an issue given that the main part of the intervention was completed in one session. Intervention site was only possible in an institutional setting given that a simulator was used. The same simulator was used for all participants. Who delivered the intervention was not reported and as such may have been one person or multiple. This potentially may have effects on the outcome. However, it is difficult to determine without knowing if there was multiple evaluators. The following lists the outcomes of this study and how they were measured. Driving performance was measured by the participant's speed and acceleration while passing an intersection. Further to this, their driving performance was measured by the amount of deceleration of surrounding traffic who had the right-of-way. Deceleration was measured as positive, no deceleration was needed, 0, there was no change in speed, or negative, deceleration was needed by surrounding cars to prevent a crash. Workload was measured by the participant's performance on a secondary task while passing an intersection. A peripheral detection task was used whereby a red square would appear in the driver's left peripheral field of view for 1 second. Drivers had to respond by pressing a button connected to their left index finger as soon as they saw the red square. Participants were considered to have higher workload when their reaction time was longer and when they missed pressing the button. The first outcome measure was the simulator, which was used to measure driving performance. The reliability or validity of the simulator was not reported in the study. Data on speed and acceleration of the participant and surrounding traffic deceleration was recorded while the participant was completing the drives. The second measure was the peripheral detection task, which measured participant workload. Reliability or validity of the measurement was not presented in the study. Workload data for reaction times and percentages missed were recorded at baseline when the participant was in the simulator in park and also when driving on a straight road. Experimental workload data for reaction times and percentages missed were recorded while the participant was driving on both drives on 28 out of 71. To appraise for measurement biases, the following questions can be asked. Were the evaluators blind to treatment status? In this study, this is not applicable in the sense that all participants received the same intervention regardless of age group they were in. However, the evaluators were aware of which type of drive the participants were completing given that the ADAS drive had verbal instructions during the drive. This could potentially have an effect on bias. Recall or memory bias was not applicable given that the outcomes were measured by a computer. I will discuss the results based on the original hypotheses. The first one, it was expected that ADAS will reduce workload for older drivers. It was found that workload was not reduced for any age group. However, age was found to have an effect on workload in that functionally older participants had higher overall workloads and functionally older participants had longer reaction times and greater percentage missed on the peripheral detection task while driving. The second hypothesis was older driver safety decisions will increase with the use of ADAS. The study found that the effective messages did not differ between age groups. However, the messages led to fewer or less strong decelerations by surrounding traffic. Overall, participant driving speeds were slower with yield and obstructed view messages. The one-way street message led to fewer route errors. Finally, the third hypothesis was that older drivers would have a greater acceptance of the ADAS technology. Contrary to expectations, opinions of the usefulness of the ADAS did not differ between age groups. Here are some questions to consider when looking at the results of this study. Was this study adequately powered? There was a high dropout rate and a low sample size, which may have affected the outcome of the study. Were the analysis methods appropriate? Although the authors explain their reasoning for adjusting the age from chronological to functional, I would wonder if this is a true representation of age. Were statistics appropriately reported? Yes, dropouts were appropriately reported and excluded from the study. The following were limitations of the study. The high dropout rate due to simulator sickness. Future studies should try to reduce factors that cause simulator sickness. The current ADAS system only included verbal messages. Future studies should include visual and physical feedback to meet the needs of various clients. The author's conclusions were appropriate given that this study did not reveal strong correlation results. The authors identified that although anticipated, the messages did not decrease workload and may have actually increased workload in some cases. So, what does this mean for Bob? From my appraisal of the mini mental state examination and with Bob's score of 24 to 30, I would not feel comfortable predicting his medical fitness to drive using this assessment. The MMSE was found to be a poor predictor of passing or failing an on-road assessment at this cutoff score. Other assessments would be recommended to adequately determine Bob's fitness to drive. From my appraisal of the study by Davids and colleagues, it was determined that this specific ADAS program that provided messages prior to drivers reaching an intersection did not have specific benefits related to age. It was found that older drivers have an overall higher mental workload compared to their younger counterparts and have longer reaction times in peripheral detection tasks. These findings could support why Bob has begun to drive slower and have been reported to incorrectly adhere to road signs. It is inconclusive whether the use of this specific ADAS program would be beneficial intervention for Bob. Further research on ADAS programming with larger sample sizes is needed. Here is a list of my references.